Thank you for joining us. My name is Per Ostmo, and I am the Program Director for the Rural Health Research Gateway. I will drop my email into the chat, so please reach out if you have any questions. If you are unfamiliar with Gateway, we provide easy and timely access to research conducted by the Federal Office of Rural Health Policy-funded Rural Health Research Centers. You can stay up to date on the latest rural health research by subscribing to Gateway's research alert emails or by following Gateway on social media. During today's webinar, the research team from the WWAMI Rural Health Research Center will share findings from multiple studies on youth behavioral health issues in the rural United States. They will be describing the prevalence of behavioral health conditions among youth, the youth behavioral health workforce, the behavioral health licensure and reimbursement policy landscape, and the provision of youth behavioral health services. Please note that all attendees have been muted, but you may submit questions for our speakers using the Q&A function. Today's session will be recorded and posted to the Gateway website for later viewing. So now it is my pleasure to introduce our presenters. We have the WWAMI Rural Health Research Center team here today, which is led by Director Janessa Graves and Deputy Director Holly Andrilla. We also have the team of research scientists from WWAMI here today, and that includes Lisa Garberson, Gina Keppel, Natalia Oster, and Sarah Woolcock. Now, this is a huge pool of talent, and I'm not going to read everyone's bios, but I will say that you can search all of these researchers on Gateway and find all of their other FORP-funded rural health publications. So now I'm going to hand things off to the WWAMI team. I believe we're going to start with Director Janessa Graves.
Hello and good morning. Thank you everybody or afternoon for some of y'all. Thank you for being here, and we're really excited to share this recent work out of the WWAMI Rural Health Research Center. We're going to cover a whole swath of information, but we're going to start off. I'm just going to give you a little bit of rundown of our team and the nature of this work. So we are a federally funded Rural Health Research Center supported by the Federal Office of Rural Health Policy, and this is one of the projects that we conducted as part of our work with HRSA and the Federal Office of Rural Health Policy. That said, the information, conclusions, and opinions expressed here are those of ours and not endorsement of for HRSA or HHS is intended to be inferred. It's a cooperative agreement that we have with them, and so it's a great work together, a collaborative work that we engaged. They identify some issues, and then we seek to answer them. And so this particular project, we were really focused on youth behavioral health access. We have published a full report in May 2026, so relatively fresh off the presses last month, and you can use this QR code to access the report. This is what the front page looks like. And what we've tried to do with this presentation is to give you more than just what's reported in the executive summary or the key findings, but kind of give you a deeper look into some of our results that are still in the full report. And so please seek out that and access that, and that is located on the Rural Health Research Gateway. In terms of the topics that we'll cover today, we are going to start out with Gina Keppel, who will be talking about the prevalence of youth mental health or behavioral health concerns. So she'll be talking about depression, suicide, suicidal ideation, alcohol and marijuana use disorder, and then reported treatment of mental health treatment among youth. I will be covering some of the information regarding the distribution of the behavioral health workforce, and then we'll be handing it off to Natalia Oster, who will be talking and speaking with you about interstate licensure agreements. After Natalia, Sarah, we're just sort of poopering. We're throwing it all over the place for y'all. We're going to be she'll be covering DEA waivered clinicians, followed by Holly Andrilla and Lisa Garberson, who will be talking about treatment and access of Medicaid and commercially insured kids for opiate use disorder. And finally, Natalia, will come back to Natalia and she'll wrap up looking at reimbursement of services. And so we're really covering the gamut from what's the distribution of the conditions that are facing kids, what does their access look like, what does the workforce look like, what are they getting, and then how is that paid for? And so to get us started, I believe the next slide is, I'm going to pass it off to Gina.
Thanks, Janessa. I'm Gina Keppel, research scientist with the WWAMI RHRC, and I'm giving a very brief high-level overview of some of our findings on prevalence of depression and suicidal thoughts and behaviors, alcohol use disorder and marijuana use disorder, and reported mental health treatment among adolescents and young adults in the rural and urban United States from 2021. Okay. There's a little delay there, but so in looking at these topics, we know youth suicide mortality rates are higher in rural and urban areas, as is the prevalence of depression and anxiety. We also know there's behavioral health workforce shortages in rural areas that can affect the ability of youth to receive treatment. So for this analysis, we use the 2021 National Survey on Drug Use and Health, which surveys adolescents and adults to generate national prevalence estimates for non-institutionalized U.S. civilians. And we calculated weighted frequencies and used chi-square tests to look at rural and urban categories and census divisions. And of note, there were some categories of rurality and census divisions where data were suppressed due to small sample sizes. To categorize rurality, we use the 2013 Rural Urban Continuum codes and also use the 5 categories of rurality as listed here. Large metro, small metro, urbanized, rural, less urbanized, rural, and completely rural. So the first analysis from this data is about depression and suicidal thoughts and behaviors among adolescents aged 12 to 17. So here's an overview of the findings. A significantly higher percentage of adolescents aged 12 to 17 in rural compared to urban counties reported they had serious suicidal ideation in the past year. And 18.2% of adolescents in rural areas and 14.8% of adolescents in urban counties reported serious thoughts of suicide, as well as 8.4% of rural and 6.3% of urban adolescents reported they'd had plans for suicide in the past year. Regarding depression, 1/5 of adolescents met the criteria for having experienced a major depressive episode in the past year, and there were no differences between rural and urban counties. However, the prevalence of major depressive episode in the past year varied significantly across census divisions, with the highest prevalence in the West, North Central, and Mountain census divisions, each around 25%, and the lowest at about 16% in West, South Central census divisions. For experiencing a major depressive episode in their lifetime, the prevalence varied significantly by rurality, with the highest percentages in larger rural areas at over 30%, and the lowest in less populated rural areas, around 24%. Okay, so the next analysis is about alcohol use disorder and marijuana use disorder among adolescents and young adults aged 12 to 24. So this analysis includes young adults, and alcohol use disorder and marijuana use disorder are clinical diagnoses that are related to impaired control over alcohol and cannabis use, respectively. So the prevalence of past year alcohol use disorder among adolescents and young adults in this age group was 9.2% in urban and 8.5% in rural counties, which was not a statistically significant difference. The prevalence of past year alcohol use disorder was lowest in the rural West South Central census division at 6%, while the urban West, North Central, and rural counties of New England census divisions had the highest rates, around 13%. And the prevalence of past year marijuana use disorder in this age group was 10% in both urban and rural counties. So this did vary significantly across U.S. Census divisions overall and within both urban and rural counties by census division. So the lowest prevalence of marijuana use disorder was in the rural West, North Central, and the rural Middle Atlantic at just over 7%, and the highest was in the urban Mountain Census Division at 14.9%. And of note, it also the highest in the rural Pacific Census Division, where the prevalence was 25.3% in rural areas, and then low at 9.6% in urban areas. And this was also a statistically significant rural urban difference within the census division. So finally, for this data, we examined reported receipt of mental health services by adolescents aged 12 to 17. And of note, these are services for emotional or behavioral problems unrelated to alcohol or drugs. So in 2021, 18.4% of adolescents aged 12 to 17 in urban counties and 18% in rural counties reported receiving specialty mental health services in the past year. So the prevalence of receiving these inpatient specialty mental health services, these specialty services in an inpatient setting was low, with only 2.5% of adolescents in this age group reporting that type of mental health care in the past year. And there was no significant variation for rurality or census division. But most specialty mental health services occurred in outpatient settings. So approximately 1 in 6 adolescents in this age group reported receiving specialty outpatient mental health services in the past year, which are services from a private therapist, psychologist, psychiatrist, social worker, or counselor. And there was no significant variation across the two categories of rural and urban, but some significant variation by rurality within the census divisions for receipt of outpatient specialty services, with significantly higher rates of reported receipt in urban compared to rural counties in the Mountain, Pacific, and West and Central census divisions. So additionally, around 15% of adolescents in each rural and urban counties received mental health services in a non-specialty setting in the past year, which includes those delivered in education, general medicine, juvenile justice, or child welfare settings. And there were no significant differences in the prevalence of these services by rurality or census division. So thank you. Now I will hand it back to Janessa for the next topic.
Thank you, Gina. So youth can potentially carry a higher burden of mental health need, but we don't see in the data that we have a huge difference in the services, in the proportion of youth who are receiving services. Thank you, Gina, for covering that so well. With the higher needs in rural, it's really important to consider what the workforce is available to treat them. And so that's what I'm going to cover here. So here's the take-home message. The access to behavioral health treatment for youth is scarce. So if you take anything home with you today, that's probably should be that. However, you probably already know that. That's why you're here. So just a little bit of background. One element of context is the access to mental health facilities for rural youth. And there just simply aren't facilities in rural areas. So across all the United States, all U.S. counties, roughly 64% of counties have a mental health facility that treats youth within that county. However, only 29.8% of rural counties have one of these facilities that will treat youth. Schools, while they're in nearly all communities, may not fully meet youth's needs either. Our previous work has shown that rural schools are 19% less likely to provide mental health assessments than city schools. An obvious workaround could be telehealth, but that runs straight into rural broadband gaps. And data from the 2020, I put data here from the 2024 census that shows that 75% of low-income rural households have broadband compared to 82% of urban households. So to see the full picture of the workforce, we needed to get a count of the providers everywhere. And so the objective of this part of the project, this larger project, is to look at the distribution of child and youth behavioral health service providers across rural and urban areas. So our approach is fairly straightforward. We turned to the National Provider Identifier Registry. So it's a registry of providers, essentially a billing fingerprint for every U.S. provider carries, and pulled 5 provider types. And the way I thought of it was, these are folks who do both youth and children, youth, adolescents, kids, and then also do them sort of the mental health side of things. And so these are school counselors, school and family psychologists, youth and family mental health clinical nurse specialists, school social workers, and pediatric psychiatrists and behavioral pediatricians. And we placed each provider in their practice county and then classified that county along the rural gradient using these urban influence codes, from urban all the way down to the most rural, small, remote communities that don't even have 5,000 people. And so we use that to calculate the supply per 100,000 youth aged 5 to 12. So what did it reveal? Here is the core finding. Urban counties have about 69 youth behavioral health clinicians per 100,000 young people, and rural counties have about 34. That's almost exactly half. The chart on the right gives you an idea of how the clinicians were classified. So we have on the left side people who care for kids. So that's the first 3 bars. And we do see a gradient there of, as the blue is urban, and then we get to micro and then non-core. So as we get more rural, we see fewer providers per 100,000 youth. The second group are those folks who treat behavioral health. So behavioral health folks, we also see a gradient. And then on the far right, we see this youth behavioral health, which there are far fewer, and that's part of the take home. And we still do see a gradient. So when we break down rural into layers, here on the left is that urban supply. And the supply erodes every time we step away from metro areas. So as the further we get from metro areas, the less supply we have. The most remote counties, small, isolated, those towns counties without even a town of 5,000 people, Those have 18 clinicians per 100,000 youth. That's barely a quarter of the urban figure. And you'll see later that part of the issue here is that these are the children who face the longest drives and have the thinnest local infrastructure, are the ones that, could really benefit from having the providers near them. And that you'll see later from some of our work that the driving is a significant barrier. So moving on to this next slide, this is looking at these 50% of US counties. So half of counties don't have a single youth behavioral health clinician of any type. And in rural counties, let's see if our thing goes here. So in urban counties, that's 25% of them do not have a youth behavioral health provider. When we get to rural counties, it's 65%. So it climbs to nearly 2/3 of that value. When we get to the most rural counties, we're talking 87% of the most rural counties have no youth behavioral health clinician. And so the national numbers also tell us something about the regionality of what we're looking at. So here is a distribution across census divisions. And in case you don't know your census division, here's your country. And the colors correspond to where they are on the map. And what you can do is look at sort of the rural south central census divisions and the east and west south central. They have about 10, so these bottom two, they have about 10 providers per 100,000. That's comparing that to New England that has 86 providers per 100,000 youth. And so that's a ninefold difference. Same country, same need, potentially wildly different reality. And so, a rural county in Vermont or Maine and a rural county in Mississippi, we know they're not the same. And maybe in workforce terms, they're entirely different planets. The deepest band we see, the deepest need band, are these gray counties in the center, and then this east south central, which is sort of this maroonish brownish color. And so this scarcity tracks with geography. And so from a policy and intervention standpoint, we could use these data to target our efforts, and perhaps with different approaches in different areas based on their needs. Now looking at this variation by provider type. So this is the number of specialized providers that are lacking in the county. And so this is dividing out, starting with youth mental health clinical nurse specialists, pediatric psychiatrists, school counselors, school social workers, and as we move down, what the availability and the percent of the counties that lack these provider types. And I think that the take-home message here is that 99% of rural counties lack some of these provider types. The best we're doing is the youth and family school psychologists, which is 75% of counties are lacking that provider type. And so what do we actually do with all of this? I think that the most important, these are some of our take-home. The most important piece that I think to think about is continued monitoring of the youth behavioral health workforce is essential. Efforts to address youth mental health access must account for the magnitude of the shortages and this geographic variation that I showed you with the census map. Certain areas and census divisions warrant targeted investment where rural counties have the lowest supply across regions, and shortages span multiple provider types, suggesting that there might be systemic barriers rather than isolated gaps. This is a systemic problem, and it's an issue within the system, not necessarily an issue with a single county. And these findings point to both supply and geographic distribution. And we need to think about that when we're thinking about strategy. So we might want to consider more providers, expanding training pipelines in rural serving programs across all 5 types. We need to extend the reach of telehealth, but pair it with broadband to make it real. We need to target the places furthest behind and look at these regional disparities. And we should build on what already works. So we know that school-based providers often reach kids in places where there are no clinical specialist might exist, or there's no clinical site, and that might be a really apt place to leverage. The point is that the supply and the distribution have to be solved together. It's not just one or the other. And so for my last slide, this is sort of what the take home is that youth behavioral health clinicians. There is a low supply, but it's in a context. Oh, sorry. Next slide. I have the wrong button. Lower supply in the context of greater need. And so that's what, we need to take forward with us as we think about these things. And so I'm going to pass the torch on to Natalia, who's going to talk a little bit about interstate occupational licensure arrangements. Thank you.
Janessa, can I jump in here really quick with a question? So a couple slides back, there was a map showing the different regions, and then I think it was the number of youth behavioral health providers per county. Was there adjustments for the difference in population for those regions?
Yeah, so that's adjusted for the denominator is the number of youth per 100,000 youth aged 5 to 17 in that region. So it's all adjusted for population size.
All right, wonderful. Thanks, Janessa.
All right, awesome. Thank you, Janessa. And hi, everyone. I'm Natalia Oster, and I'm going to be talking about interstate licensing models. Oops, sorry. Jumped ahead. Okay, so for background on this topic, most interstate licensing agreements take place through interstate compacts. And for a definition, interstate compacts are legal agreements between states to work together to address a variety of shared policy issues. So compacts are really used for a wide range of cross-state issues like emergency management services, foster care services, adoption, shared water resources, and many other things. States are also using compacts to make it easier for licensed professionals to practice across state lines through professional licensing compacts. And a key reason for these arrangements is that occupational licensing is usually very fragmented across the states. So states typically have different requirements for education and training, for supervised clinical experience, background checks, and continuing education, among many other things. And that variation can really make transferring a license complicated and time-consuming. So the goal of compacts is to simplify the process of transferring a license from one state to another, or practicing potentially in multiple states. So our study objectives were to describe state policies that expand behavioral health services through interstate occupational licensure arrangements. And for our methods, we reviewed professional association websites and the literature to summarize licensing models for 5 specific behavioral health professions. So we looked at psychologists, social workers, licensed professional counselors, marriage and family therapists, and school psychologists. And we chose those behavioral health professions because each has either an active or developing compact arrangement or a portability initiative. So then moving into the results, we found that interstate licensing models really fall into two categories, the most common being by far compact agreements, and then the other are license portability laws. In occupational licensing compacts, participating states adopt identical licensing laws in each state, and that allows behavioral health workers, for example, a social worker with a license in one compact state to practice in another participating state without needing to get a separate license. So in the context of these 5 professions that we're talking about in this presentation, the compact model is being used by psychologists, social workers, licensed professional counselors, and school psychologists. And then rather than developing a compact, the American Association for Marriage and Family Therapy is focused on developing license portability laws. And in contrast to compacts, license portability allows states to retain their own licensing standards, but it really streamlines the process for becoming licensed in another state. All right, let's see. Sorry, I'm having some problems progressing. All right, so the next 4 slides show maps of states participating in each of the active or developing compacts. And I used maps directly from the individual compact commission websites, which are current as of now, as of June 2026. And as you'll see, as we walk through these slides, the compacts really are in various stages, so ranging from very early development to operational. The most developed compact is the PsyPact. That's the compact for psychologists, and that's the map that's shown here. And at the moment, 41 states and Washington, D.C., that are shown in dark blue are participating in the compact. And then two additional states, Louisiana and Iowa, which are in light blue, have enacted legislation, but they're not yet up and running as part of the compact. And then four states that are shown in black, Alaska, Hawaii, Massachusetts, and New York, have introduced legislation, but haven't passed the legislation yet. And then the three states that are shown in gray don't currently have, they have no active legislation. All right, so then moving to the compact for licensed professional counselors. This compact is active in 6 states, and those states are shown in green. Then 32 states and Washington, D.C., that are shown in dark blue have passed legislation, but they're still working out logistics. So, for example, integrating their state license databases with the national compact database, that actually takes several years potentially for states to kind of get up and running. And then legislation has been filed in Pennsylvania, New York, and Michigan, and that's shown in yellow. And then 9 states don't have any active legislation, and that is shown in gray. All right, so then moving to the Social Work Compact, this compact is still in development. As of June 2026, 32 states have passed legislation, and that's shown in dark blue. And then New Mexico, shown in yellow, have passed kind of a modified version of the compact legislation, but it's not yet a full compact member. And then legislation is pending in 4 states in DC, shown in light blue. And then the gray shows 13 states with no active legislation. And this compact is expected to go live in about a year in the spring of 2027. All right, so then moving to the final compact state, final compact, this is for interstate school psychologists. It's the newest compact, and it is really just getting organized. So as of June 2026, legislation has passed in 8 states and has been filed in 5 states. And then all the states that are shown in light green don't yet have legislation passed. All right, so then, sorry, I apologize about my slides and that they're not quite progressing right for me. So then just a final slide on marriage and actually let me just go back to so that you can see the school psychologist. I'm not sure if you actually saw that. So again, a compact that's very much in the beginning stages. All right, so then moving into a final slide on marriage and family therapists. So as we briefly talked about before, rather than developing a compact, the AAMFT has developed model portability laws. And at this point, 16 states have passed this model legislation. And then 7 additional states have passed laws that are similar to the model legislation and are considered portability friendly. And then there are efforts in 4 states to develop legislation, and that includes California, Michigan, Pennsylvania, and Rhode Island, and then no current efforts in the remaining 23 states. Sorry, I do have one more slide. Okay, so just to recap the main points, interstate licensing arrangements for behavioral health providers really are in the early stages. Future evaluations will definitely be needed to really understand how these licensing models impact cost, access, and quality of behavioral health services. All right, and that's all for me, and I'm going to pass things on to Sarah.
Hey, thanks, Natalia. So my name is Sarah Wilcock. I'm also a research scientist at the WAMI Rural Health Research Center. So I'm going to briefly be sharing the results of a data brief that we did as part of this project to describe the supply of clinicians with a DEA waiver to prescribe buprenorphine. So to start with a bit of background, one of the barriers that youth face in accessing care for opioid use disorder is the limited availability of clinicians who provide opioid use disorder treatment to youth. And one form of treatment for opioid use disorder in adolescents includes medication treatment for opioid use disorder. And buprenorphine is one of the recommended medications for treating opioid use disorder in adolescents. So on this slide, this is a timeline showing the legislative changes that have happened in the past 25 years to expand the workforce who can prescribe buprenorphine. Until recently, eligible clinicians had to complete training and then apply to the DEA to obtain a specific X waiver before they could prescribe buprenorphine for opioid use disorder. But most recently, this requirement to obtain a waiver was eliminated starting in January 2023. So that was great for clinicians. They had one less barrier to providing this care, to start providing this care to their patients. But with that, it also eliminated the registry that the DEA kept that tracked the eligible workforce that can provide buprenorphine to their patients. So for this project, we wanted to take a last opportunity to describe the availability of the workforce that's eligible to prescribe buprenorphine before that waiver requirement and that registry went away. So to do this, we used data from the DEA from 2017 to 2022 to provide a 5-year look back. And we assigned all clinicians in the registry to their county and then classified counties based on the USDA urban influence codes, the same classification Janessa talked about. And then we broke down the rural counties by UIC into 3 separate categories. And UICs use the closeness to a metro area and population size to classify counties as more small and more remote rural counties. And then in each county, we calculated the counts of clinicians in each county and also adjusted for population, the clinicians per 100,000 population. Oh, and one limitation I just want to note before I jump into the results is with the DEA registry is that with this data source, we can't specifically determine which clinicians in the registry specifically treat youth and adolescents, but it does give us a general idea of the available workforce that could potentially do that. All right, so this is that last snapshot from 2022. This chart is showing the percent of counties with and without a DEA waivered clinician in 2022. The urban counties are in that first blue bar, and all the rural counties combined are in that dark green bar. And then the subsequent green bars are showing the different levels of rural broken out. So we see that in total, of all rural counties, about 30% of rural counties did not have a DEA waivered clinician in 2022 before the waivered requirement was eliminated. That's in comparison to urban, that only about 10% of them did not have a DEA waivered clinician. And then looking at the different categories of rural, we see again that the small and remote rural counties have the least access, where only about 60% of those counties have access to a DEA waiver clinician. And this chart is showing, we also looked at the change in the supply of waiver clinicians in the 5 years before the waiver requirement was eliminated. So this is showing the population adjusted supply of clinicians from 2017 to 2022. And we can see in all 5 years, rural counties had a lower supply compared to urban counties in the number of clinicians per population. But over that time period, that 5 years, the growth in rural counties was slightly higher. Rural supply per population grew 320%, whereas urban, it grew 268%. And then we also, again, looked at the availability of waivered clinicians regionally. So this is a map showing the supply of waivered clinicians just in the rural counties. All the urban counties are whited out. The red counties are counties without a waivered clinician. The yellow counties are rural counties with only one waivered clinician. So they would be at risk of potentially losing their one single provider if that provider stopped providing this treatment service for whatever reason. And then all the blue counties are showing different levels of supply. So the lightest blue have 2 to 3 clinicians, and the darkest blue have the most. So we do see that in the central mountain states, up from Montana, North Dakota, down to Texas, there is a lot of area there where there are a lot of counties that either don't have a provider or they have very few. So those are places that that would have major implications for access to treatment with buprenorphine in those particular areas. All right, thanks so much. So now I'm going to pass it on to Lisa and Holly.
Thanks, Sarah. My name is Lisa Garberson. I'm a research scientist with the WAMI RHRC. And today I'm going to talk to you about 2 of our studies. We looked at the rural-urban variation in the distance traveled for care by children and adolescents with an opioid use disorder diagnosis. For youth with OUD in rural communities, there are fewer treatment options and a number of barriers to getting that treatment. So for our studies, oops, sorry, so a bit of delay. For our studies, we looked first at the commercial claims and then Medicaid claims, and they were both for calendar year 2019. There we go. And so our sample was children and adolescents aged 0 to 17 who had a claim with a diagnosis code of opioid use disorder or opioid overdose. And on the bottom of the slide there, you can see the number of enrollees we had in the commercial sample and the number of beneficiaries in the Medicaid sample. So we defined a single visit by rows of data with the same patient and Benny ID, visit date, and servicing provider NPI number. We used zip codes to calculate one-way driving distance and travel time between the patient location and the servicing provider practice location. We used the practice location as a proxy for place of service because we did not actually have a zip code for the place of service in the data we used. So okay, so let's see. But one thing, sorry, I'll go back to the next one. We could not calculate driving distance for beneficiaries and patients who were in the same county as the provider, or the same zip code as the provider. So for those, we imputed 0 for one-way driving distance. In the policy briefs for both of these, we provide the imputed values and with the imputed zeros, the distance numbers with the imputed zeros and without the zeros, so you can see both of those. This was a county level analysis. So we used the 2013 urban influence codes. We had metropolitan urban and non-metropolitan rural. And now I'm going to hand it off to Holly to walk you through some of our results.
Thanks, Lisa. So I'm going to just share findings from one piece of these two studies. And to start, I want to just orient you to this particular slide because I'm going to look at it a bunch of different ways. On the left-hand side, you see all those beneficiaries and enrollees for commercial insurance. And on the right-hand side, you see the numbers for the beneficiaries with Medicaid insurance. And then within each of those sort of broader columns, you see the rural, urban columns individually. So let's start with comparing within patients with commercial insurance, how far does a rural patient, and these are all for youth, have to travel as compared to an urban. So on average, rural patients travel 23 miles compared to 12.9 miles for urban. So about twice as far. And it probably actually is twice as far because I am reporting findings that have those zeros included. So anytime somebody got care in the same zip code as they lived, we had to count that as a 0. And we did include those because the differences look bigger if you exclude all the close visits. And so, and there are more rural people that see a patient in the same zip code. So it's about twice as far as the take-home message. And if we look at the same thing for Medicaid, we see a similar pattern. Rural beneficiaries with Medicaid insurance travel, can you believe it, almost 81 miles on average for care for opioid use disorder as compared to 45. And I think 45 is huge as well. Now, the next sort of logical comparison to look at is what about if you are comparing types of insurance and ignore the rurality for a minute. So urban beneficiaries with Medicaid insurance travel on average 45 miles as compared to urban commercially insured patients about 13 miles, about 3.5 times farther. And we see that same, it's like a little slow to move ahead. You see that same pattern when you compare rural Medicaid insurance patients to commercial insurance. They travel about 3.5 times farther. And we've got the times there too, if you're interested. If you take those, let me go back one slide for just a minute. If you take those rural patients that traveled 80 miles on average and you just look at them and you just look at the Medicaid. So this next slide is just the Medicaid enrollees and just the rural. And you look at it across the rural continuum, you see that the 80 is true overall, but as you move from left to right on this slide, you move from the I'll say least rural to the most rural. That is, you move from counties that are adjacent to a metropolitan county to small and remote counties that are not adjacent to a metropolitan or a micropolitan. So really the smallest places. And look what happens to the average. It just steadily climbs. So the story of 80 is true for a lot of people, but it's even more, even a farther distance for people in the most remote places. So kind of what's the take home? And rural children and adolescents travel twice as far as their urban counterparts, regardless of their insurance. But rural children with Medicaid insurance carry the largest travel burden. They travel twice the distance as their urban counterparts and more than 3 times, about 3.5 times farther than commercially insured rural children. So why is that? We have some ideas. Stigma is one of them. Providers don't always want to provide care. But this group is kind of interesting because there's also a big problem with the lack of available specialty care. In the rural population that we looked at, we could tell the specific age of the patients, and about 10% of that sample were babies, less than 1 year old. So they required and then about almost another 20% were 1 to 4 year olds. So that group of patients were people that were born with opioid use disorder because their mother was using drugs during pregnancy. And so the level of specialty care that they need is likely not available in a rural place. For older kids, there's a concern for families maintaining anonymity in a rural community. And if you live in a rural community, you're familiar that everybody knows your business, and maybe this isn't business that you want everybody to know. However, if that was the only reason, if those were the reasons, we wouldn't see the big additional disparity between commercial and Medicaid insurance. And so likely the very low reimbursement rates for the Medicaid population is contributing that. Providers can't afford or choose not to afford to provide services when the reimbursement rates are so low. And Natalia is going to, I think, finish us off with talking about some of those reimbursement rates.
Yep, that's right. Thanks, Holly. All right, so I'm going to be talking about Medicaid reimbursement for youth behavioral health services. And so for background on this topic, as all of you will know, youth behavioral needs are rising at the same time that we have a lot of behavioral health provider shortages. And a key workforce piece is really how providers are reimbursed. Medicaid is the single largest both provider and funder of behavioral health services in the U.S. It covers about 20% of U.S. residents. However, it does cover a disproportionate number of rural children. Research suggests that about 47% of rural children are covered by Medicaid and CHIP versus 40% in urban areas. So just continuing with some brief background on Medicaid funding and administration that's relevant here. Medicaid is jointly funded by states and the federal government, but it's administered by the states. So states determine billing, reimbursement, coverage policies, and other things. And this results really in 56 distinct Medicaid programs. So the 50 states plus DC and the U.S. territories. And then adding to that variability, Medicaid reimbursement policies also vary by the patient's age, by care setting, and by eligibility criteria. So because of this state-by-state variation in reimbursement and coverage policies, the goal of our study was to summarize reimbursement for behavioral health services for Medicaid beneficiaries ages 0 to 24 in all 50 states and the District of Columbia. Moving to the methods, we reviewed Medicaid provider and billing manuals for all 50 states in DC for 3 specific behavioral health occupations. So we looked at social workers, marriage and family therapists, and psychologists. And then we also separately reviewed individual state reimbursement policies within school-based Medicaid programs for school psychologists. And the reason for doing that is that school psychologists typically are not enrolled as independent Medicaid providers. Instead, they're typically reimbursed through school-based Medicaid programs. All right, so then just moving into our main findings, this is as of November 2024. It's not I should say that the policies change frequently. So this is as of 2024. Medicaid reimbursement was available in both community and school-based behavioral health services for psychologists and social workers in all 50 states and DC. And you can, I don't know if you can see my cursor, but you can see this in the second and third column that psychologists and social workers are fully covered for both school-based and community-based. Um, Less coverage for sure for marriage and family therapists. So in contrast, marriage and family therapists were reimbursed in school-based settings in 34 states, and then 16 states in DC did not provide coverage. And then looking at the bottom right cell, MFTs could bill Medicaid for community-based services in 48 states and DC. And those two exceptions, the two kind of missing states were Pennsylvania and West Virginia, which at the time did not reimburse marriage and family therapists for community-based services. But since then, West Virginia has actually begun reimbursing MFTs, and Pennsylvania does offer now some limited coverage through certain managed care programs. All right, then just final results that I'll be sharing here. Medicaid billing and reimbursement policies vary very widely both between and within states. So for example, some states offer multiple Medicaid plans, such as fee-for-service and other managed care plans. Some providers are covered by some Medicaid benefits and not others. And then, interestingly, but I thought it was interesting, at least, benefits are also sometimes differ by provider setting. So in some states, reimbursement is restricted to services provided in a clinic or community mental health center or another institutional setting. So just to recap in conclusion, most states provide some level of Medicaid reimbursement for youth behavioral health services, for social workers and psychologists and MFTs. Fewer states do cover MFT reimbursement for school-based Medicaid programs. And I believe that's my last slide. So thank you so much. And I'm going to be passing things back to Janessa.
Thank you. So before I pass it back to Pear, and we're happy to answer questions, so please put them in the Q&A. I just sort of as a summary statement, the challenge, that we've cited here from our work is not that it's simply one need or one workforce. It's a mismatch between where the youth needs services and where the services actually are. And so rural communities face potentially higher burdens of some behavioral health outcomes, while they simultaneously have to navigate having fewer local resources and greater barriers to care, like the driving times that we talked about. So improving youth behavioral health in this context in rural America does require some targeted place-based solutions that expand workforce capacity, they reduce access barriers, and ensure that all youth can receive timely, appropriate care, regardless of where they live. And the link to our policy report, I believe, is in the chat. And I am curious if there are any questions. All of our work can be found at the Rural Health Research Gateway.
Thanks, Janessa. So we do have a few minutes. While everyone takes a couple of minutes to type their questions, I'll review a couple housekeeping items. The recording, transcript, and slide deck will be available, if not Friday, then next week, Monday. If you have questions about anything you've heard today, you can feel free to send an email to the researchers. All of their contact information is on Gateway, or you can send an email to me or the Gateway general inbox. If you don't know who to reach out to and you have a question in general about rural health research, always feel free to email Gateway and I can connect you with a researcher who specializes in whatever area that you're interested in. So thank you to our presenters for presenting, and to anyone asking questions. We'll check the QA one more time.
I have a question.
Yep,
can I
Janessa,
ask?
go ahead.
I'll just fill up the world with questions. So this question is for Holly and Lisa. Rural Medicaid youth traveled the furthest of any group, and I think of driving time all the time because I live in a very rural area and also have to drive, in my case, that's 65 miles one way. Given the possible drivers that you listed, so you talked about stigma, specialty care, scarcity, anonymity concerns, reimbursement, which lever do you think would reduce that travel burden the most? And is telehealth a realistic substitute for that population?
Okay, unless you're dying to take it, Lisa, I will.
No, go ahead.
So I think that for me personally, I think that the most realistic, quickest lever is improving reimbursement. I think that that is a huge barrier for rural populations for providers. However, it only matters if there's a provider there to improve the reimbursement for. And so I think expanding our workforce is really key. There has been a huge increase in, I reported the findings for opioid use disorder, but there's lots of other things that people need help for. But there's been a huge improvement in the workforce in, I will say, the last 10 years that can provide care for opioid use disorder. So I would love to see, and we've seen the expansion of marriage and family therapists being their billing capacity. So I think expanding the workforce and removing some of those barriers to providing care for people, having practitioners work at the top of their scope is going to be really key. When you say broadband improvement, I mean, or telehealth, that goes hand in hand with broadband. You live in a rural place, so that is a lot of people say, oh, we can just use telehealth, but that isn't a realistic solution at this moment for rural communities. So that's another thing that the federal government and others have been talking about for a lot of years, but we definitely need to improve that if that's going to be our go-to answer.
Fantastic. Thank you. There is a question in the chat. Would you please detail, this is from Meredith, what you see as potential solutions to these issues and as specifically as possible? And there are a lot of solutions. So I would say first check out our report because we do talk about some solutions in the key findings, and at the end of the policy reports, we have some suggestions or some considerations. I think personally, one thing to think about is that these are some structural challenges that we are facing. And so instead of building something new in a community is leveraging the structures that are already there. So be it a really active youth center or senior center or schools, because that infrastructure already exists. And could we leverage that infrastructure to get something off the ground more quickly than say, building a whole clinic or something. Similarly, pipeline programs matter, and pipeline and pathway programs matter, and they're very important. They do take some time. And so I think working on different timescales, if you're working in the long time scale, think about pipeline and pathway programs, which are critical, but also thinking about the shorter terms and what sort of changes can be made around reimbursement or the way care is delivered, whether we're leveraging schools or we're leveraging other community resources can be a quicker component to address some of the challenges that youth are facing. But there are a lot of different potential policy levers or interventions and that could be employed. And please send us an email. It's really fun to talk about this stuff, and I'd love to chat more if that's something you're interested in, Meredith. And then Alejandra says, what are your thoughts on helping potential providers of behavioral health services with billing and Medicaid reimbursement, given the climate of the Medicaid budget? And so I am not sure if this is kind of the technicalities of reimbursement and how to handle billing and reimbursement, or if it's the entire climate of this as a potential source of services or a reimbursement of services is potentially going away in some circumstances. For the former, I think there are technical assistance services out there that can help with billing for billing Medicaid and being able to do that. And then for the latter, I might pitch it to Holly because I know she has a million great ideas and she might have a better idea on. She's laughing at me.
Thank you. I was trying to see the question. For some reason, I can't see the question. So
it says, what are your thoughts on helping potential providers, quote unquote, of behavioral health services with billing and Medicaid reimbursement, given the climate of Medicaid budget?
Yeah, well, what will I say? Yeah, I do think that the technical support is important, but as Janessa said, I do think a lot of that exists. Of course, it's different for every state, right? Because Every state, Medicaid is a state federal partnership, and so that further complicates it. My in my interactions with clinicians that are hesitant to use Medicaid or to accept Medicaid, it's not so much that they don't know how to bill it, it's that the amount that they are getting is very small, and the time that it takes to get it, both in terms of paperwork and then actually getting paid, having the money, is so long that they just say, it's not worth it. I've got people that can pay me more in a more timely fashion. I don't want to sign up for this extra administrative burden and the wait time for the money. So I think that we really do need to address that. Or we need to, or we need to figure out ways to, I will say, have a larger share of the clinician population or provider population, whatever you want to call them, participate. Because if everybody did a little, of course, it would be workable. It's that everybody doesn't do a little, and then that makes the burden really fall heavily on some groups.
Yeah. We have some other work looking at how Medicare expanded the workforce to include and be reimbursed for marriage and family therapists and mental health counselors. And one of the challenges in some interviews we've conducted with key informants is sort of the administrative barriers and these challenges with billing Medicare. Certainly, it's potentially even more complex with Medicaid. And so one of our suggestions or considerations for that was trying to address some of these administrative challenges to make it easier for folks to serve those kids or folks.
Well, thank you. We don't see any other questions in the Q&A, so big shout out to the WWAMI Rural Health Research Center team for presenting here today, and a big shout out to all of our attendees for asking such excellent questions. I hope to see everyone at future Gateway webinars, and have an excellent day. Thanks again. Bye, everyone.